Okay, so today we're going to go over just a bunch of different systems, whatever we can get through. But I'm going to start with respiratory disorders. I would definitely say for your exam with her to look through the drug guide. It should be called the Common Drugs for the Respiratory Disorders. She'll definitely I don't know, she doesn't give a lot of questions about medications, but if she does, and she will probably put a few different medications that she might want you to know, this chart would be really helpful because whatever question she does take would pretty much come from this section that says nursing implications. Like she will ask you like what do you use it for if she puts a drug. So I would like go into those. It doesn't really change for pediatrics like everything that you've learned in pharmacology. So I wouldn't like get too crazy with it, but it would be good to like review it and know it because there's going to be um a lot of important medications that are going to come up and we also need to be aware of how we use them and what to look out for, especially because we've spoken about how pediatrics, right, because of them just being in this developmental stage where they're still growing, they can have more adverse effects to medications than an adult would. So knowing what can happen as a consequence of the medications that she specifies is just really important. Also because it is more likely to occur in the younger kids. But the first respiratory disorder is tonsillitis. It could also be called pharyngitis. It's usually viral, especially for children, but it could also be bacterial. And it's typically, if it is going to be caused by a bacteria, it's going to be caused by group A beta hemolytic streptococcus. I would know that because she would definitely ask you, like, what bacteria could cause that. Even if it were a select all, she would include that. If they said, oh, they have bacterial pharyngitis, what do you expect, right? Oh, like the cause is group A beta hemolytic streptococcus is blah, 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 blah. Like, so I would know that. And this is also an example of a picture. The reason I put a picture in there is that she does tend to like to show pictures, especially as we get into the disorders. This is just a picture of what tonsillitis or pharyngitis can look like. You could just see how swollen those tonsils are, all that like exudate, just from like the inflammation. So there's definitely a lot going on here and you could just this is one of those disorders you could see based on a visual examination, but if we suspect that this child has tonsillitis or pharyngitis, we can't just go based off looks. We have to do a few different things. For a diagnosis, you need to know this. It's going to be a rapid strep screen and throat culture. That's what we're going to do. We're going to get a culture test. So we're going to determine if it's like bacterial in nature. And if it's negative, the rapid test, we're going to send for a throat culture just to make sure we rule all our bases, right? Because sometimes it can come back negative, but it's a false negative. So we're going to do a rapid test and a throat culture to see if there's bacteria present and all that. And the assessment of throat, as I said, is going to be a huge indicator of what's going on as well as their symptoms, right? That includes like a sore throat, a fever of greater than 101. They're going to have pharyngeal inflammation and anything that ends in itis, right? So pharyngitis, tonsillitis means inflammation. So if you can think of that while you're taking your exam, like, okay, this is tonsillitis. This is inflammation of the tonsils, inflammation of the pharynx, whatever. So that means I expect to see some sort of swelling, right? And swelling would lead to difficulty swallowing, right? Because if it's all swollen, it could just hurt and decrease the ease of swallowing. They could even have enlarged palatine tonsils, which is typically what you'll see in tonsillitis. So it depends. Like I said, the tonsillitis pharyngitis is where it's located, but they can be used interchangeably. But when we have pharyngitis, obviously it's the inflammation of the pharynx, but all the other symptoms are the same. Whereas tonsillitis, right, it's going to be inflammation of the tonsils, specifically the palatine tonsils. And they're also going to have halitosis, which means bad breath, and they're going to be breathing through their mouth a lot. Um, Medications, right? Well, we have to figure out what it's caused. That's why we do a rapid strep screen and a throat culture. Is it bacterial in nature? If it is, that means we have to think bacteria, antibiotics. And typically penicillin type antibiotics like amoxicillin, penicillin, all of those are first choice, but no amoxicillin. Amoxicillin is the one that she likes. Like penicillin type antibiotics are going to be very commonly the drug of choice for our pediatric population, but I would know amoxicillin especially for her. Warm saline gargles. So that basically just means like also like warm salt water gargles because that's going to actually help soothe the pain and the redness. Acetaminophen is the drug of choice for fever. Keep that in mind. Remember, we never give aspirin. We never give that. I'm just saying that even though it doesn't really relate to this, but I just want you to know never give aspirin, okay? Like if you ever even see that as a select all, just never give it. It can, we'll get into why later, but I just want to remind you of that. Um, Also, for tonsillitis specifically, they may do a tonsillectomy. It's not really the treatment method of choice anymore because you don't want to have a procedure that's so invasive and, it could put you at risk for infections, especially for children. So, it's not really the ideal, but if they do, they'll watch. If this is a type of patient who, maybe every month or every few weeks is getting sick with a strep infection, they should get a tonsillectomy, which will be removal of the tonsils. And she will ask about the pre-op and post-operative management for a tonsillectomy, and I would definitely focus on that. I also wanted to point out why would, if I'm saying we don't really want to do invasive procedures, why would we, be worried about that? Like, if it's just strep throat, right, you could treat it. Yeah, you could treat it, right? But you'll actually learn when we're getting more into the chapters that if you do not fully treat a strep infection or you get recurrent streptococcal infections, because remember, we said this could be caused by a group A beta hemolytic streptococcus, um, they can actually go into I can't think of the name exactly. I'll see it when I remember, but it's a type of acute kidney failure. A child can go into kidney failure from having recurrent strep infections. Like I said, I can't think of the name, but it's like acute glomerulonephritis, something like that. Um, and yeah, so basically tonsillectomies would be less of a worry than if they keep getting these infections because it could eventually affect their kidneys and eventually put them into kidney failure if, things don't go as planned. So I just wanted to point that out there because you're going to be learning about that soon, but just to give you ideas to why it's kind of scary. But yeah, remember, this is bacterial and they're having a sore throat. So we want to help manage their symptoms. So when we're talking about fevers, right, warm saline gargles, antibiotics, right? If it's viral in nature, we're not giving antibiotics, things like that. Um, okay, so for tonsillectomy, if they're gonna have that, there's really important things that we need to take note of. So, the first thing is that um pre-op teaching, right? We need to tell them about, hey, the parent and the child that they're going to have a sore throat for a week or more after the procedure. It's not going to just be a few days. It's going to be a week or longer. We're going to tell them to eat soft foods while they're in this preoperative teaching, like what they should be doing afterward, right? Like they're going to be eating soft foods after. Like this is our education. All right, we're teaching them before the procedure and letting them know that they are at risk for post-operative bleeding. So we need to be aware of that. So before the procedure, we need to get labs, right? We need to get um, a CBC. We want to look at their RBCs, right? Their red blood cells, their hemoglobin, their hematocrit, right? We want to know what those levels are baseline because they're at risk for bleeding. And we know if someone bleeds, those levels like hemoglobin and hematocrit are going to decrease, as well as we want to look at WBCs for risk of infections, right, and platelets because platelets need to be normal so that if bleeding does occur, the body can naturally stop it. If they're too low, they're at risk for bleeding. And no preoperative antibiotics. Keep that in mind, okay? We don't want to give them anything preoperatively. Um, Intraoperatively, so during the procedure, we will give them a single dose of intravenous dexamethasone, and that's a corticosteroid just to help reduce inflammation, right? Because remember, we're doing an invasive procedure in the area of the throat, so it's going to be inflamed, and that inflammation could make it, harder to breathe postoperatively. For post-op, we need to look at quite a few different things. Is that one, like I said, they're going to have difficulty swallowing. They just had a procedure on their throat. So we want to give them liquid forms of either ibuprofen or acetaminophen, things like that. Um, we do not give any opioids for pain management, like that contain codeine in children less than 12 years of age. Okay, we will not do that. Um, Other things include that until the patient wakes up, they need to be in a side lying or prone. Know that, a side lying or prone position to notice post-operative bleeding until they're fully awake, right? While they're still in that um anesthesia-like state, right, where they're still kind of drowsy and not really, awake yet, we want to keep them on the side because as they're on the side, we could actually watch, is their blood dripping actively from the mouth, right? Like things like that. Other things is that a really question that I see come up a lot, especially on like ATI, but on her exam, she's going to ask you like, what would be an indicator post-operatively that this child is bleeding? If they're continuously swallowing post-operatively, that can indicate bleeding, and we need to assess that immediately. We want to monitor for indications of hemorrhage, like I said, continuous swallowing being one of them. We want to discourage coughing and clearing of the throat or even blowing the nose because remember, they're having like a invasive procedure in your throat, right? If they cough um really hard or sneeze really hard or clear their throat really hard, that can remove things like um stitches and whatever's going on. No straws, okay? No straws or anything sharp. They cannot suck on things. It's the same idea. We don't want them sucking on anything that can just make everything worse. And no suctioning, okay? For pain, we have ice collar because remember their throat is inflamed. So ice helps with inflammation, not heat. And we want to give them liquid medications like ibuprofen, acetaminophen, right? Some things that are easy to swallow, right? Not anything hard. That's why we're not giving them pills. We also have a clear cold liquid diet, so we want to avoid um anything that's brown, red. And why would we want to avoid liquids of that color? Because they're at risk for bleeding. So if they're gonna drink a red Gatorade or they're gonna have a red icy, right? I might think they're bleeding if they start to drool, right? In their like, you know, their sleep or something, or just see it coming from the side of their mouth. But to prevent that confusion, we don't want to give them any of those like colors as well as any sort of citrus juices or sodas because that could just be really harsh on the throat. Um, okay. Another, is there any questions before I continue?
What year old does the tonsillectomy affect?
Mm, If I would say pretty much it would be like children like preschool age, I would say would be children who would typically undergo a tonsillectomy. Because it's
Oh,
mainly the kids that, get affected with it. I mean, like I said, it's for having like strep throat, it's okay to get it like,
mhm,
once in a while, but if it's excessive, that's why they'll have a tonsillectomy. Like my cousin
mhm.
is 19 now, but she actually had a tonsillectomy because she was getting so exposed to strep infections that she needed to have one. Like it could have been detrimental to her health. Um, so there's no like age maximum, but I would definitely say around preschool age, so like 6 to 12 would probably be more where this sort of occurs.
Okay. Because I was just making sure, you know how you were explaining about straw and stuff. I'm like, do babies also get it? Like, I wasn't sure.
Yeah, probably not. It would probably be hard to do it on a baby, especially because I don't think they would be so exposed to streptococcal infections yet. It'd be
Mhm.
kind of hard. But yeah, I would say this is more for like a preschool age.
Oh, oh,
Yeah,
thank you.
you're welcome. I also see another hand raised.
Yeah, I was wondering, does that also like can it disrupt like your sleeping? Like if you were like your breathing, if you were to have like inflamed like tonsils?
Do you mean like if you have tonsillitis, could that affect like the way you sleep?
Yeah, because it's inflamed.
Yeah, for sure. Because also we said one of the symptoms is mouth breathing, right? So that's kind of hard to do, right? When you have like an infection and you're trying to sleep and you're breathing through your mouth, I would definitely think it could cause sleep disturbances. And even the procedure, right? Getting a procedure where they're going in your throat and removing your tonsils is also going to cause inflammation. So that probably will also be a temporary period of trouble sleeping. Um, okay. So the next thing is croup, which is also called laryngotracheobronchitis, which they just call croup, which is nicer than that word. And this actually has an age period, usually between 3 months and 3 years, and it's a group of illnesses, and it causes an inflammatory process. What that means is that inflammation, right? There's some sort of inflammatory response in that area, because this is the anatomy of it, right? The croup is occurring, or what it is, it's an inflammation of the larynx, the trachea, and the bronchi, right? That's going to cause airway obstruction because of all that swelling and could cause some degree of respiratory distress. This acute airway obstruction is predominantly in, like we said, in children between 3 months. It could also be occurring again in like 6 to 8 years of age, but typically between 3 months and 3 years old. It's a viral infection, okay? This is viral, which means there's no antibiotics, right? Because this is a virus. It's a virus that's attacking the larynx, the trachea, and the bronchioles. What are the causes? Well, there's two common causes of croup, and we said it's a group of infections. So usually the infections that are causing this are RSV, or respiratory sinusoidal virus, and influenza A and B. Those two combined are going to cause this inflammatory process and cause obstruction, leading to hard time breathing. So we know that this is going to cause a hard time breathing. It actually occurs most often at night because, like we said, when you're breathing through your nose, but the air is not being able to travel as much because of all that inflammation, right? And especially we know that our bronchi and bronchioles are leading to our alveoli for gas exchange. So if that's really inflamed, it can feel very hard to breathe. They'll have a low grade fever. They're not going to really have like over 101, maybe like 99.9, 100, but not over 101. A really key characteristic that they have croup is that they have a hoarse or barking cough. They almost sound like a seal. They can have tachypnea and tachycardia, which makes sense, right? If they're having trouble breathing, they're going to breathe faster to try to breathe and get some air in, and they're also going to have an increased heart rate as a result. They could even have wheezing and inspiratory stridor, especially at night. I would keep note of that, as well as retractions. They could be agitated and restless and have cyanosis, which makes sense because, once again, right, it's airway being really inflamed, may not be able to get to the alveoli as as much air should be. There should be more air going to the alveoli, but it's not because there's so much obstruction. So their cells are not getting enough oxygen that they need, so they become um they undergo hypoxemia, and they become make your skin cyanotic as a result. Um, so the diagnosis is typically the way the child sounds. And like I said, the key characteristic is, or I would say the three key characteristics is that it occurs at night, the hoarse barking cough that sounds like a seal, and that inspiratory stridor, especially at night. Those are your key takeaways. And actually, when you're in class, she will play for you what it sounds like. She like gives you a video. So yeah, diagnosis is how the child sounds. But it could be treated at home. So we don't want them to cry, right? Because the crying is going to make their respiratory effort even harder. We can allow the child to sit up in your arms. So we said this could be a 3-month-old, so we have to make sure they're sitting upright to, facilitate breathing. They should have rest and lots of fluid intake. Remember, this is viral. If stridor occurs, if we hear that, remember we said especially at night, we want to put them in a steamy bathroom for 10 minutes. And that's because the steam is going to help open up the airways. We also could administer corticosteroids as directed because corticosteroids, um, help reduce inflammation. And remember, this is an inflammatory process. We also need to watch the child closely, right? If they're starting to breathe faster than normal, they're having retractions now, right? So we're seeing like they're using extra muscles in their chest and in their abdomen to breathe, and they're showing signs of difficulty, call the physician, right? If they have nostril flaring or their lips or nails are bluish, that means it's getting worse. They need to go see the doctor. They need to go now they need to go to the hospital, but this is getting more severe, right? If the cough and stridor is not improving with the steaminess that we said they can do, they need to go to the doctor. If the restlessness increases and the child's becoming more confused, they need to see their doctor. And if the child begins to drool and they cannot swallow, they also need to seek medical attention. Of course, comfort, hydration, humidified air, because that's also going to help with the airways. Um, Basically mist, like a vaporized mist, things like that, would really help. Also, like cool vaporized mist, because that coolness could also just be good for that inflammation. Um, but yeah, so anything that's like moist in air, right, helps open up the airways. So that's why they might run like the bathroom and like put steam into the bathroom for like maybe 10 minutes and then have the child go in so they could feel the steam and things like that. Worsening indications, like we already talked about, pretty much if they're agitated, they're restless, they have an increased use of accessory muscles, they're showing nasal flaring, all of that's not good. Blue nails, no. If they're going to be in the hospital, right, we can position them 30 to 45 degrees. We want to keep them calm and have the parents hold the child. But remember, this is an airway issue. So our overall goal is to make sure we maintain a patent airway. One thing that we can give is a nebulized racemic epinephrine, which is a bronchodilator, which would be used with oxygen to reduce the edema and bronchospasms that they're having. So before we give it, we obviously need to assess breath sounds so we know what we're dealing with before and after. Like, is the medication helping? We want to monitor for any changes in respiratory status. And we also need to be aware that rebound stridor can occur. And if we're thinking about, oh, we know epinephrine's a vasoconstrictor, how is it a bronchodilator? Well, it could also, act on those beta 2s, and we know beta 2s are one of their key things that they do is they bronchodilate. So it can be used as a bronchodilator, specifically nebulized racemic epinephrine. Um, Other things that we will give is oral or nebulized corticosteroids to help decrease that airway inflammation. But remember, same concept applies, right? You give a bronchodilator first, then the steroids. And that's because one, we want to open the airway with the bronchodilator, and two is that the bronchodilator is going to work quicker than the corticosteroids. So we want to make sure that we give that. Um, we give the bronchodilator first, then the corticosteroid. And in addition to that, the corticosteroids also enhance the effects of the beta 2 receptors. So we want to make sure that we give the bronchodilator first, then the steroid. I just wanted to give you reasons as to why, so it makes sense. Acetaminophen if they have a fever, right? We already said humidified oxygen, IV fluids with isotonic solutions, and if they have moderate or even severe hypoxia, it could lead to intubation. Any questions? Okay, so like I said, we already talked about key takeaways, but since I already mentioned medications, definitely go back into the chart and look over some of those medications that I talked about before if she mentions them. Okay. So another thing is acute epiglottitis. Okay, it is like a croup syndrome. However, unlike croup, because croup and acute epiglottitis can almost mimic a lot of the symptoms can be very similar and it could be confusing. But the difference between this and croup is that it has a high fever, acute epiglottitis. It has a rapid onset and there's no barking cough. That's what separates this syndrome from croup. It's also a life-threatening infection. It is viral, but it's caused by Haemophilus influenza, which can lead to complete airway obstruction. Okay, that's scary. This is usually between ages 2 to 8, and like I said, it has just a very abrupt onset, and it could actually be decreased with the HIV vaccine. I think I have to double check what that is. I don't remember abbreviations. Oh yeah, so it's the Haemophilus influenza type B vaccination. Sorry, wouldn't have known that on top of my head. But if they're given that vaccine at a young age, that could help reduce getting acute epiglottitis. But like I said, this can lead to severe or very extreme or complete airway obstruction. So what kind of symptoms do they have? Well, they're going to have respiratory distress. They're going to have a sudden high fever, an extreme sore throat, agitation, lethargy. They're going to use retractions. They're going to have their mouth open. They're going to be looking like they're air hungry. They're going to just keep sitting there with their mouth open, trying to get air in, but it's really hard for them. And a few other things, what we call the 4Ds, is dysphonia. They're going to have a really high-pitched voice, and that's because the airway is becoming so obstructed, right? Because it's still affecting the same airways as croup, right? The larynx, the trachea, the bronchioles. So if it's going to affect the larynx and it's going to cause like almost complete obstruction, that's your voice box, right? So it's going to cause this high-pitched sound. They're going to have dysphagia, so they're going to have really trouble swallowing. They're going to drool. Drooling is very characteristic with acute epiglottitis as well as distress. These are the 4Ds. And they have a typical classic tripod positioning where they're sitting almost over the bed with their mouth open, trying to breathe, and they can't. The child is typically anxious and agitated, and be aware that the child who suddenly appears calm, or if you cannot hear adventitious breath sounds, they could have complete airway obstruction. Um, Also, a really key takeaway that you must know is that their throat is going to be very edematous, right? It's going to be cherry red. It's going to be bright red, but you cannot examine or visualize the epiglottis or the throat. You cannot sit there and put a tongue blade into the throat. You cannot ask to open them and assess the throat, okay? Anything that goes into the throat, you cannot do. You cannot open their mouth and use a tongue blade to look around. No. You're not going to do that. You're not going to put anything into the throat. Okay? You have to wait until emergency intubation equipment and qualified personnel are available. You cannot shove anything near their throat. Okay? So yeah, like they could open their mouth and you could look, but you can't visualize it with a tongue blade. You can't put anything in the throat, okay? So nothing in the child's mouth until there's an immediate tracheostomy in this situation. Um, Remember, our goal, like the other one, is patent airway with respiratory support. There also needs to be an X-ray at the bedside because we need to confirm what's going on in the chest area, and we also want to confirm if there's an enlarged epiglottis. We need to maintain an upright position in a tripod position, so we just need to keep them upright. We want to make sure we have IV fluid, strict intake and output. Antibiotics and antipyretics may be ordered. Remember, they're going to have a fever, so we're probably going to have antipyretics. Now, and this is not a bacterial infection, but you're at risk for infection because of the fact that they're having acute airway obstruction and they're going to be intubated, so they might just get prophylactic antibiotics. Dexamethasone, right, for to decrease airway edema. Dexamethasone you're going to see is a very common pediatric used corticosteroid. Um, Intubation or tracheostomy may be necessary. And like I said, we cannot put anything into the mouth. Know that because she's going to ask you that. Um, Also in the textbook, I'm not going to get too much into it, but I did find the comparison chart, um, 40.2, very useful just to kind of see the difference because like I said, they're very similar, but they affect different age groups. So I would look at this just to help you compare like what's kind of going on here. Okay. The next thing is bronchiolitis, which is another type of viral infection, typically by RSV. But remember, bronchiolitis means inflammation of the bronchioles, which means there's edema and there's also an excess accumulation of mucus. And remember, anytime there's like a respiratory problem and there's a lot of water buildup, you're at risk for infection. So that's always scary. That's why it's so easily communicable because it's so infectious, right? And it's also causing excess mucus and kids are, they touch everything. They put everything in their mouth. So very easily spread. And it's usually in children under the age of 1 and it peaks at around 6 months of age. The symptoms, it's usually like they almost are similar to an upper respiratory infection, like sneezing, nasal congestion, a low-grade fever, anorexia. But worsening indications would be tachypnea, tachycardia, nasal flaring, retraction, rales to crackles to rhonchi, apnea, sinus, any of those things that doesn't seem like a regular like upper respiratory infection would indicate the condition's worsening. The diagnosis is based on the presentation, and we also will do an RSV antigen test from like a nasal swab. Um, for those seriously ill children because we said this could be caused by RSV. Um, there's usually home management, so that'll include like rest, fluid intake, fever management, and a bulb syringe. So basically, they'll try to like use the bulb syringe to like excrete or remove any excess like secretions. Because remember, we're talking about a very young age baby in like the 6 month area. It's not as easy for them to excrete their mucus. So we might use a bulb syringe to like suction or remove maybe if there's a lot of mucus in their nose or their mouth or whatever, right? If they're dehydrated and or even experiencing respiratory distress, right, we want to use cool, humidified oxygen. If you see that on a Selectol, rule of thumb, I would pick it, especially for these respiratory infections, because we that mistiness really helps with inflammation, but and helping breathing. Inhalation of like hypertonic normal saline solutions, IV fluids, elevating the head of the bed, right? Respiratory, you can't never go wrong. Respiratory, elevating the head of the bed, and they must be on contact isolation. So they can be in the same room with other children who have it, but we need to take special precautions with these. Um, okay. Other things is that for medications, right, bronchodilators. So there's albuterol and there's Exapanix. I don't know how to say that, but that one, the one that starts with X, has less side effects but is more expensive. And albuterol, the issue with that one is that it's cheaper, but it causes tachycardia and it can cause restlessness. So it's kind of like pick or take, but one of those we get bronchodilators, right? Corticosteroids. Remember, bronchodilator, then the corticosteroids. And something that I know she's going to ask on your test is RSV prevention in in high risk patients like our preterm infants, because preterm infants are at highest risk for developing RSV, which could lead to something like this, right? To like bronchiolitis. So we must give this pal palivizumab, which is also called Synagis. It's given in the fall after discharge, and it's given every month to prevent them from getting RSV. I would know that this is the medication you're going to give to prevent RSV in high risk preterm infants. Know that. Okay. Another common respiratory disorder is asthma. And we know about asthma, right? It's chronic inflammation. It's another inflammatory disease, right? Pretty much they all are, right? It's causing edema, bronchoconstriction, bronchospasms, right? Mucus thickening. There's a lot going on, right? Risk factors are anything that could trigger asthma, like it could be allergies to things like dust, pollen, mold, pet dander, so they should avoid those triggers. And also, a family history of asthma can increase the risk of asthma. So we know, right, a key characteristic of asthma is wheezing. But other things that they have is a tight, non-productive cough. They could have chest tightness, tachypnea, tachycardia. You do notice anytime there's tachypnea, there's tachycardia. So you could put those two together, right? Dyspnea, maybe nasal flaring and use of accessory muscles if it gets really bad. And restlessness. So for diagnosis, there's a few different things. So we usually do the measurement of airflow through a spirometer in children greater than 5 years of age. Know that. Also, that the best measure is a peak expiratory flow rate, which is basically used to see in patients who have chronic asthma if their medications are working. So there's the green zone, where the green zone is really good. That's usually 80 to 100%. That means, okay, they're treating their asthma, they're controlling their asthma, no signs of distress. Yellow means, uh-oh, the asthma is worsening and they need to follow their action plan to get back into the green zone. So maybe taking their bronchodilator and things. If they're in the red zone, that means, uh-oh, the medications are not working, the asthma is not being controlled, they're probably having a really hard time breathing, and they need to seek medical attention immediately. And basically, what this test is measuring is the fastest speed at which air is forced from the lungs during expiration, right? How well are you able to um, force air out of your lungs through expiration? That's what it's looking for. Because if you can't do that, right, then that means you can't relieve CO2, which means you can't breathe properly. Improvement of symptoms is usually could be response to these nebulized bronchodilators. And if they have a history like of allergies or allergic manifestations, that could be something that could tell us, hey, they could be at risk for asthma. Just a bunch of different things. But like I said, the best measure is the peak expiratory flow rate. But for children greater than 5 years of age, we usually measure of airflow through a spirometer. Um, Treatment, like we said, avoid triggers. Um, we know that we will give a bronchodilator first before we give a corticosteroid. Usually we'll give short acting. I would just know that you're going to give a bronchodilator, something like albuterol, um, and things. I would not know all of the high dose, medium dose, low dose. I don't think she'd expect you to know that. But once again, if they're having a severe asthma attack, we need to give them a short-acting bronchodilator like albuterol. A long-acting like salmeterol will not help these patients because it's going to take too long to open the airways and they can die. So no, 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 we need to give a short-acting bronchodilator or our SABAs, right? For management, it's right assessing for respiratory distress, using the pulse ox and like looking at the child, right? Are they looking blue? Are they looking like they're really struggling to breathe? Positioning them properly, like having the head of the bed high, right? Like assessing breath sounds, um, giving your bronchodilators and your corticosteroids, assessing the response to medications, which we could do through that peak flow, IV access, and avoiding cold liquids because that could just further exacerbate the asthma. Um, I'm not going to get into all of the guidelines for how to teach um, a patient how to use the medication delivery systems, but I would review this because she may ask a question about that. But there's a few different types. I don't think she did on my exam, but I would know that, the difference between like the nebulizer and the meter dose inhaler. Um, and that children can use a spacer, especially for those meter dose inhalers, which is almost what you're seeing in the picture to the right. So, like the spacer just sort of helps creating a better seal for them to breathe in their medication. So, I would just know that. Okay. Another really common respiratory disorder is cystic fibrosis. Now, this is an inherited um, disorder, and it's usually autosomal recessive, and it affects a lot of the exocrine glands. So basically, this includes like your sinuses, your lungs, your skin, your liver, your pancreas, your intestines, and even your reproductive organs. So these, a lot of organs are affected, okay? Um, Basically, what happens is there's an dysfunction with the exocrine glands leading to abnormal sodium and chloride levels. It's one of the things they always ask on the NCLEX or when it comes to cystic fibrosis is how it's caused, and it's an accumulation of chloride levels. And there's this increased viscosity or thickness of mucus secretions, and there's an increased susceptibility to colonization with bacteria. So that's another thing that's happening. And we also have something like it's called like a mucociliary like elevator or escalator. I don't know what it is, which word it is, but basically, right, we have a method in our lungs to help remove things that we're not supposed to, and the chloride and sodium uh levels help regulate that to help get rid of mucus when we don't need it. And when someone has cystic fibrosis, those mucosal escalators can't do that. They can't move those excess mucus secretions, so it could be very scary, and that's why there's an increased production of thick mucus in things like the bronchioles, the small intestines, the pancreatic and bile ducts. So it kind of starts affecting lots of places in your body because we can't get rid of them. We can't get rid of that mucus because the chloride and sodium levels, um, they can't do what they need to do. Um, so, with that in mind, it affects a lot of the organs and it could basically cause, for example, for your skin, because of all that excess mucus production and that thick mucus kind of lining up everywhere, they could have really salty sweat. their lungs are going to be like really thick with mucus buildup, so we don't expect the lung sounds to sound good. They're probably going to be diminished, right? They're going to have sinusitis. They're going to have infections because of all this mucus buildup. The pancreatic ducts are going to be blocked, which means they're going to have problems with digesting their foods, as well as the intestines are going to be blocked up, so they can't fully absorb nutrients, and it could even affect um the reproductive organs in terms of like being able to give birth, and things like that. So, um, manifestations, like I said, we said with the lungs, it can cause infections. So they could have these dry, non-productive coughs that's eventually going into more purulent and copious based on how much, secretions there are. They could have a huge history of respiratory infection just because of all this mucus buildup. They'll have crackles, wheezing, diminished breath sounds, all the things I already said with retraction, dyspnea, right? They could have digital clubbing, right, which indicates hypoxia because of all this mucus blocking all these airways. Um, they could even go into death because of all this mucus buildup blocks the airways so much they die. We already said their skin's going to be salty, and that's because of the high concentrations of sodium and chloride. Digestively, they're going to have um, something called paralytic ileus or meconium, where basically the baby doesn't poop after they're born. So after they're born, they're supposed to poop within a certain amount of time. The babies are not doing that. When they do poop, they're gonna have I don't know how to say that word. Steria? I don't know. Satoria, but whatever that is, this word. Um, basically it means that they're having fat in their stool, and it's causing this frothy, like foul smelling stool. They're gonna have malnutrition, and they're going to have growth failure. Even though they're intaking, maybe they're eating properly, they can't absorb all of it, so they're going to have growth failure despite maybe having good caloric intake. They're going to be also deficient in vitamins A, D, E, and K due to their inability to absorb fats. And reproductively, males can be sterile and females could be infertile. So how do we diagnose that? Well, there's a newborn screening and there's a prenatal screening to determine if they have that. If they have a history of a lot of upper respiratory infections, that could let me know, hey, they might have cystic fibrosis because they're getting too many upper respiratory infections too often. But the diagnostic test is a positive sweat test. So this is when it measures the amount of sodium and chloride in the sweat. It's only completed once. And basically, if the sodium slash chloride level is above 60 milliequivalents per liter, they have cystic fibrosis. Know that number. So, treatments, remember, we have a lot of different organs going on, but one of them is respiratory, which means we need to maximize their lung functioning. So we need to do a good respiratory assessment, which is our priority, right? Includes breath sounds, respiratory rate, O2 stat, capillary refill, color of skin. And our goal, like we said, it's respiratory patency. But what we want to do here is that they have so many secretions, we want to get rid of those secretions. We want to mobilize them. We want to get rid of them from the lungs. We also want to prevent and treat any infections with things such as antibiotics. We want to manage any pulmonary complications. We also want them to have they're gonna have like forced exhalation or huffing. Uh, that's something we could sorry. They can have something done or explained to them, which is called huffing, and we're basically forcing them to exhale so they can get rid of those secretions. We could even use positive expiratory pressure devices to help with breathing. Um, but chest POT and post-oral drainage really promotes huffing. So remember, huffing is this idea that we're forcing things out, and we use chest PT and post-oral drainage to help with that. We could even do vibrations to loosen secretions, breathing exercises, swimming also can help with removing secretions, as well as humidified air. And low flow oxygen of 2 liters per minute or less. And if you see in the picture of the right, in like on the right hand side, it's basically like a chest that basically vibrates at a really high frequency to help break up mucus. So it's really good. And you see this a lot in patients' homes for people who have cystic fibrosis. And it's very easy to use. And it really helps with removing them to allow them to cough and get rid of those secretions. Other things that we will do is that we need to maximize nutritional intake. So, they basically need dietary supplements of fat-soluble vitamins like A, D, and K. Why? Because we said they can't absorb those. So we need to give them supplements that are fat-soluble so that they're still able to get their dietary needs. They also need a high caloric intake and high protein intake to help support those needs. We want to prevent and monitor for respiratory infections. They need routine immunizations because they're very much at risk for infections, and we need to support normal growth and development. Um, Other things in terms of medications include we have an inhaled recombinant human deoxyribonuclease or D DNase, which is basically things like a mucolytic, um, which is like mucimist or pulmozyme, I'm going to say it like that, to loosen and thin pulmonary secretions and facilitate removal by coughing. Because remember, mucolytic, muco meaning mucus, and lytic getting rid of it or breaking it down. So it helps remove the mucus and it breaks it down. They might get antibiotics. Remember, they're at risk for infections. And all kids with cystic fibrosis take pancreatic enzyme. Remember, pancreatic ducts are blocked, right? Because of all that mucus buildup because of the cystic fibrosis. So, they need to take pancreatic enzymes, and it helps improve digestion and absorption of fats, carbohydrates, and proteins. They have to be taken with all meals or snacks. If they do not take their pancreatic enzymes with their foods, they're not going to be able to absorb their food, and they need to. And they're going to take their pancreatic enzymes for the rest of their life. Any questions on any of that? Okay, so the last thing I'll go into is chapter 39, which is basically ear infections, specifically otitis media. So, uh, otitis or otis media, whatever, is inflammation of the middle ear, right? So, media being middle, otis being ear, so middle ear. There are two types. She's gonna ask you to differentiate between the two types. So there's acute otitis media or AOM, and there's otitis media with effusion, aka fluid, right? Which is OME. Children under 3 years old are very vulnerable due to their just ear anatomy, and that's because those Ascasian tubes, which basically are open to help regulate pressure in the ear as well as airflow, are short, wide, and straight. I would know that. She does ask something about that. So that puts them more at risk for ear infections. It could be viral or bacterial in nature, and it's actually associated with finger with cigarette smoking and poor feeding techniques. So we talked about, right, how you need to feed babies properly, especially if you're doing like the breastfeeding method to latch onto the areola. If they're not doing that, that can affect they can have a higher risk for otitis media. And if they're always around a parent who smokes, that can also increase their risk. So, acute otitis media, their manifestations include otalgia, I'm gonna say it like that, which is really significant pain in the ear. And they're gonna have this bulging, opaque, tympanic membrane, which is kind of what you're seeing over here with arrhythmia or redness and decreased like mobility and obscured landmarks. So basically you can't really see what's going on in the ear. You'll see like this redness, this opaque like tympanic membrane, like you see in the right, that redness that we were talking about, that bulgingness. And there's gonna also be even drainage. I would know these manifestations. For treatment, know this part too. The treatment, if they have acute otitis media under 6 months of age, they're gonna get oral antibiotics like amoxicillin. Know that. If they're under 6 months and they have acute otitis media, they're gonna get oral antibiotics like amoxicillin. If they're older than 6 months of age, um, actually, the first intervention is going to be adequate pain relief. We want to watch and really see what happens in 48 hours. We don't want to just give them antibiotics right away. So our first or our priority intervention for someone who's greater than 6 months of age is going to be adequate pain relief. We want to make sure we provide symptomatic relief and observe them for 48 to 72 hours, especially for children greater than 23 months of age. If they have a fever, um, give antibiotics if that fever is greater than 102.2 only, okay? We want to reassess and initiate treatment after 48 to 72 hours of observation. If we determine after 48 to 72 hours that, they're still having a persistent fever, right? They're having really not much, symptomatic relief, then we're going to give them amoxicillin 80 to 90 milligrams per kilogram per day for 5 to 10 days. Know that. And we want to encourage risk reduction. So, like I said, greater than 6 months, we're talking about the first intervention is adequate pain relief. We're going to watch them for 48 to 72 hours. We're looking to see is that fever greater than 102.2, right? We'll give them antibiotics. If it's still really high, we're going to observe them and potentially give them amoxicillin 80 to 90 milligrams for 5 to 10 days. But it all depends. This is after, right? Like 72 hours, 48 to 72. This is unlike the under the 6 months of age where we just give them the oral antibiotics immediately. And prevention also includes vaccinations like influenza type B or HIB, and then pneumococcal vaccines as well that can help prevent some of this. Um, Otitis media with infusion or OME is basically this, it's an issue where there's fluid behind the eardrum, and it's usually a chronic condition. The difference between this and the other one is we said the other one had really bad pain. This one does not have pain. This one is also going to cause conductive hearing loss. And you'll also notice that a child has this if they constantly rub their ears. If they go towards their ear and start rubbing it a lot, they could have otitis media with effusion. They also will have speech-related problems. Remember, if you can't hear words as well, you're not going to be able to speak the words properly. Indications that they could also have it could include hearing loss if they're complaining of ringing in their ears, if they have a retracted tympanic membrane. The treatment for this is pretty much a watchful waiting. Know that. Just watching to see what happens. Because like I said, it's we want to try to remove the fluid, but we're not going to do anything right away. We want to see what's happening. And they could also, if it's that bad, go do something called a mirroringotomy, which is basically when they surgically drain fluid from these like little tiny tubes in their ear. And other important teaching points, if a child does display signs of this, is that we want to feed the child in an upright position, um, just as like a general thing, because that's going to help with alleviating pressure while they have this effusion. Because imagine, right, you have really big, bulging fluid in your ear and you're sideways, right? You're sideways. It's going to put a lot of pressure. It's going to hurt the ear more than if you're up and with gravity. Um, Another thing is that if they have the mirroringotomy, sorry, I know I'm not saying it right. They're gonna also have these insertion of these little what we call tympanostomy tubes. So they're gonna get these little tubes that they're gonna put in their ear to help remove the fluid. And when they do that postoperatively, they're gonna give pain, right? Encourage fluids and also give antibiotic ear drops potentially because they just put tubes in the ears. Now, depending on the doctor and what they say, they may or may not need to avoid water or use earplugs. It depends. And the tubes that they put in to help remove the fluid could extrude and fall out, usually like a year, like after a year, it could happen. And they'll have no more problems. That's normal. The tubes can fall out, but they are going to put these little tubes in there to help drain the fluid out. Um, and yeah, so that's pretty much all I have to say with that. Is there any questions?
Did she ask any questions based off autosomal recessive inheritance?
I don't think she asked that for cystic fibrosis. I don't think she asked like what it is. I mean, I would just know it's an autosomal recessive disorder, but I don't think she specifically asked that. She more or less focused on like the things like the pancreatic enzymes, the positive sweat tests, like what to look for, um, and like the medications you give, things like that.
Oh, okay. Thank you.
Okay.